Thank you for joining us today for our webinar on food allergy myths. I am Joni Wong, Director of Education and Healthcare Initiatives at Food Allergy Canada, and I have with me Dr. Susan Waserman. During our session today, we'll be covering common myths on different topics, like the use of antihistamines. You may have heard about the recent issue raised in the media about first-generation antihistamines such as Benadryl. Dr. Wasserman will be covering this topic later on in her presentation. There will also be time for questions at the end, so I encourage you to submit any questions you may have in the chat question box throughout the webinar, and we'll try to get to as many of your questions as possible. So before we get started, I wanted to note a couple of housekeeping items. First, all participants are muted so we can keep the audio clear for the webinar. And secondly, this webinar will be recorded and shared on foodallergycanada.ca afterwards, in case you want to refer back to it or share it with others. At this time, I'd like to introduce Canadian allergist Dr. Susan Waserman. She is a professor of medicine in the Division of Allergy and Clinical Immunology at McMaster University in Hamilton, Ontario, and the director of the Adverse Reactions Clinic at the Firestone Institute of Respiratory Health at St. Joseph's Healthcare. Dr. Waserman is president of the Canadian Allergy, Asthma and Immunology Foundation and past president of the Ontario and Canadian Societies of Allergy and Clinical Immunology. She is also a member of the Healthcare Advisory Board for Food Allergy Canada. Now, over to you, Dr. Waserman.
Well, good morning, everybody, or I should say good afternoon on this stormy day. Thank you very much, Joni, for your introduction, and I'm delighted to be presenting this webinar on food allergy myths. There are many myths about food allergy, and these are some of the most common that I hear in my practice. The smell of peanut butter causes anaphylaxis. Antihistamines can be used to treat anaphylaxis. Anaphylaxis always involves hives, and it's okay to eat a may-contain product. So let's begin with some of the food allergy basics. Myth number 1, food allergy is not so serious. And in fact, food allergy can lead to symptoms of an allergic reaction which can be life-threatening. When someone has a food allergy, their immune system mistakenly thinks the protein in a certain food is harmful. It overreacts by producing antibodies called immunoglobulin E or IgE. This is the central antibody in allergy. These antibodies, when they bind their culprit food, cause cells called mast cells to release chemicals such as histamine, and there are other mediators as well which mast cells release. Histamine leads to symptoms of an allergic reaction which can become life-threatening. Food allergy is different than food intolerance, which I will explain more later. Our second myth is that food allergy only affects a small number of Canadians. About 7.5% of Canadians report having one or more food allergies, which is more than 2.6 million Canadians based on a population of 35 million people, which is the most recent 2016 census data. This also includes about 500,000 kids. Food allergy also impacts about 50% of the Canadian households. Risk factors for food allergy include family history. You're more likely to have a food allergy if your parent or sibling has one, though there is certainly spontaneous allergy as well. Already having a food allergy. You're at greater risk of developing another food allergy if you already have a food allergy. And then number 3, related allergic conditions. Your risk is increased for having a food allergy, especially if there's another allergic condition such as eczema, but also hay fever and asthma. So let's move on to myth 3. Only certain foods cause an allergic reaction. Some foods are more often associated with allergic reactions, and you see them in this graphic. Health Canada refers to these as priority food allergens, and they need to be included on a food label. However, almost any food can cause an allergic reaction, and it's not just confined to these priority food allergens that you see in the slide. The priority food allergens include peanut, tree nuts, egg, wheat, milk, soy, sesame, fish, and shellfish. So let's move on to food allergy and testing for it. And myth number 4 is that food allergy and food intolerance are the same thing. And in fact, they are not. The fact is that food allergy and food intolerance are totally different. Food allergy involves the immune system, and symptoms can be life-threatening. If you will recall, IgE antibody binds that food allergen, causing cells called mast cells to release histamine, leading to symptoms of allergy. Food intolerance is the inability to digest or absorb certain foods. Food intolerance affects the gastrointestinal tract primarily and can cause discomfort, but symptoms are generally not life-threatening. A common example is lactose intolerance, where people do not have enough of the enzyme lactase to break down the lactose sugar found in dairy products. Myth number 5. A positive skin test and/or blood test is enough to diagnose a food allergy. The main tests that we use in allergy for diagnosis of food allergy are skin prick and blood tests, both of which demonstrate the presence of IgE. But positive tests are not enough to diagnose food allergy. In fact, both of these are sensitive tests and they can give false positive results, meaning that the test results indicate allergy when there isn't one. So a convincing history is absolutely necessary in order to make this diagnosis in conjunction with positive skin and/or blood tests. Sometimes a medically supervised oral food challenge is performed as the most accurate way to confirm a diagnosis of food allergy or to rule it out. There are also tests out there called IgG tests to certain foods. These claim to be able to diagnose food allergy, but they have not been scientifically proven. And due to the lack of evidence to support its use, many organizations, including the Canadian Society of Allergy and Clinical Immunology, have recommended against using IgG testing to diagnose food allergy or food intolerances and sensitivities. So let's move on to myth number 6. Food allergy is a lifelong condition. And the fact is that not all allergies are lifelong. Allergies to peanut, tree nuts, and shellfish, which includes both crustaceans and mollusks, tend to be lifelong. But some allergies, such as milk and egg, are often outgrown by school age, and peanut allergy may be outgrown in about 20% of individuals. One U.S. study showed that children who were allergic to milk, egg, or soy were most likely to outgrow these allergies. There's also some additional data, however, to show that children may be outgrowing milk and egg allergy, but at a later age than school age as initially demonstrated. The likelihood of outgrowing shellfish, tree nut, and peanut allergies was significantly lower. Myth number 7, adults don't develop food allergy. And the fact is that adults often do develop food allergy. Though food allergy often begins in childhood, it can develop at any point in one's life. A recent U.S. study revealed that food allergies are not only common, but severe among American adults, often starting in adulthood. Their findings from this study showed that 1 in 10 adults can have food allergy. However, even more so reported it on the initial survey that they did have food allergy, However, closer exploration of some of these patients did reveal that their symptoms were more consistent with food intolerance. In any case, a prevalence of 1 in 10 is certainly a lot higher than anybody imagined previously for the adult population. So let's move on to the specific food allergens. And myth number 8 says that it's better to delay the introduction of allergenic foods into the baby's diet. And clearly this was something that we were told many years ago. New recommendations, however, are totally different. In January 2019, the Canadian Pediatric Society released new guidelines on the specific timing of introduction of allergenic foods for high-risk infants. It recommends actively offering foods containing common allergens to babies around 6 months of age, but not before 4 months of age, as this can be an effective strategy in preventing food allergy in some high-risk infants. This recommendation is supported by the Learning Early About Peanut Allergy. This was a famous study called the LEAP study, which is an acronym for Learning Early About Peanut, and this study examined the introduction of peanut at 4 to 11 months in high-risk infants and found it helpful in preventing allergy. All of this information is a shift from the Canadian Pediatric Society's prior guidance, which said that there was no need to delay the introduction of common allergenic foods beyond 6 months of age, but they also did not give specific guidance at that time about introduction of allergenic foods between 4 to 6 months. And clearly other U.S. allergy societies and pediatric organizations have given similar recommendations. Myth number 9, it is okay for someone to eat a little bit of their food allergen. The fact is that when someone has a food allergy, even a small amount can cause an allergic reaction. And there are 3 general exceptions to this rule. One is oral immunotherapy. Oral immunotherapy is now a strategy, still in the research domain for the most part, which may permit small amounts of the food to be eaten. OIT, or oral immunotherapy, is a means of desensitizing the food allergic individual, where they are slowly fed the allergenic food, starting slowly and in a safe manner under medical supervision, at least initially. Baked egg or baked milk. Because heating alters the protein, baked egg or milk may be safe for some food allergic individuals to egg or milk. Again, the initial introduction of this is done under medical supervision and then carried on at home until the child naturally outgrows these allergies, which they should do in most cases. The third example is highly refined oils. Due to the way that they are processed, highly refined oils such as peanut and soy may be safe to consume. I don't routinely recommend that peanut and soy allergic people always depend on this to be the case, and you have to look out for how these oils are processed. Some are made by cold pressing, and this will not destroy the protein as the highly refined oils will. So let's move on now to myth 10. If you're allergic to peanuts, avoid all legumes. Peanuts are legumes. They grow underground and they are part of the legume family, which includes things such as green beans, peas, and lentils. The majority of peanut allergic individuals, however, are able to eat legumes. In the past, we used to think that most peanut allergic people were also legume allergic. This has not been borne out over time. Lupin, another legume, is an emerging allergy at this time, especially for people with peanut allergy. So talk to your allergist about the safety of eating other legumes, which most individuals should be able to do with peanut allergy. Our next myth, myth number 11, if you're allergic to tree nuts, avoid peanut. Tree nuts such as almonds and cashews grow on trees, but having a tree nut allergy doesn't mean that you're necessarily allergic to peanut. Also, an allergy to one tree nut doesn't mean you're allergic to all tree nuts. Talk to your allergist before eating tree nuts that are not part of your regular diet, and certainly skin and blood testing, as well as oral food challenges, can help define those tree nuts that are safe for you to eat. Myth number 12. Avoiding allergenic foods during pregnancy and breastfeeding prevents food allergy in your baby. At this point, our general belief is that women do not need to avoid certain foods during pregnancy or breastfeeding, and this sort of messaging is also defined in current guidelines, including those of the Canadian Pediatric Society. There's no evidence that avoidance prevents allergy, and if anything, the current thinking is that continued exposure builds tolerance in children. So let's move on to myth number 13. If someone has a food allergy, it's okay for them to eat a may-contain product. The fact is that may-contain statements are voluntary. They are not part of Canadian food labeling regulations. And some manufacturers include this statement when there is a chance that a food allergen might be present in a product. The element of risk is not known with a may-contain product. If someone is allergic to a food, they should avoid products that may contain their allergen. Research shows that some products with this warning have contained enough allergen to cause a reaction. When in doubt, avoid and certainly check back with the food manufacturer for additional information. So let's now discuss signs and symptoms of food allergy and anaphylaxis. Myth number 14 is that anaphylaxis always involves skin symptoms like hives. The fact is that anaphylaxis occurs without hives in about 10% of cases. And in fact, where hives are not seen, in certain case series, this has delayed proper treatment of anaphylaxis because it led to a lack of recognition. Let's just go over some of the symptoms of anaphylaxis, which generally include 2 or more of the following body systems: skin, respiratory, gastrointestinal, and/or cardiovascular. In the skin, this will include hives, swelling of the face, lips, tongue, eyes, cheeks, itching, warmth, and redness. Respiratory, which involves breathing, includes cough, wheezing, shortness of breath, chest pain or tightness, throat tightness, hoarse voice, nasal congestion, or hay fever-like symptoms, with runny, itchy nose, watery eyes, and sneezing. There may also be trouble swallowing. Gastrointestinal or stomach. This may lead to symptoms of nausea, pain or cramps, vomiting, and diarrhea. Cardiovascular, involving the heart. Patients may appear paler than usual, where their skin almost has a blue color. Their pulse may be weak. They may pass out. There may be dizziness or lightheadedness, and eventually shock. And then other symptoms: anxiety, a sense of doom which may be commonly described by patients, the feeling that something bad is about to happen, headache, uterine cramps, and a metallic taste in the mouth. It should also be noted that according to current definitions, a low blood pressure alone, which is part of the cardiovascular system, in the absence of other symptoms, can also represent anaphylaxis. What you see from here is that it is a myriad of different symptoms, and you have to keep an open mind to the presence of anaphylaxis. So let's now speak about triggers and reactions. In myth number 15, The smell of peanut butter can cause an anaphylactic reaction. An allergic reaction is caused by the protein in a food. Food odor, such as the smell of peanut butter, does not contain protein. If someone smells the food they are allergic to, it may make them feel anxious or uncomfortable. But smelling a food is different from inhaling airborne proteins. In myth number 16, airborne food reactions do not happen. Someone can have a reaction due to particles of protein that arise into the air and are then inhaled. For example, a person with fish allergy inhales the steam produced by the cooking of fish. Another example is milk allergy, where a milk allergic individual inhales milk in powdered form, opening a bag and having a puff of powder released. While rare, the inhalation of airborne proteins can occur, but by far the major food reactions are after ingestion of that culprit food. So let's next move on to myth number 17. An allergic reaction always happens within minutes of eating a food. Reactions often occur within minutes. However, the time frame can vary up to several hours after exposure, which can lead to some confusion sometimes with this diagnosis. Also, there can be a second or biphasic reaction, which can happen after initial symptoms have resolved from the first reaction and in the absence of any further allergen exposure. Biphasic reactions appear to be more likely when administration of the first dose of epinephrine was delayed. The second reaction can be less severe than the first reaction, the same, or more severe. Myth number 18. Allergic reactions get worse with each exposure to an allergen, and I hear this very frequently from my patients. The fact is that the severity of a reaction is unpredictable. Reactions can range from mild to severe and can vary from person to person as well as from one reaction to the next in the same individual. Different factors called cofactors can lower the threshold at which one reacts. These include asthma, general health at the time the food was eaten. Does that individual have an infection? Did they consume alcohol? Was a medication involved? Medications such as anti-inflammatories, NSAIDs, are also important cofactors. And lastly, exercise. If somebody is on oral immunotherapy or has just received an allergy injection, we tell them not to exercise for a certain period of time after. So let's now move on to treatment and emergency procedures. And our next myth is that oral immunotherapy cures people of their allergy. Oral immunotherapy is a potential treatment for some individuals with food allergy. It's a medically supervised treatment in which a person eats small amounts of their food allergen in clinic or hospital initially and then in home settings. The allergen is given in gradually increasing amounts until the person can eat a certain amount without reaction, so long as they remain on this treatment. The person is still allergic to the food, but reacts at a higher amount of the food than they did prior to oral immunotherapy. It should be noted that in the majority of individuals, if they stop this treatment, the allergy tends to recur. Myth number 20. Antihistamines can be used to treat anaphylaxis if given as soon as the reaction starts. The fact is that epinephrine is the first-line treatment for anaphylaxis and not antihistamines. It reverses symptoms of an allergic reaction and is more effective if given early. Epinephrine autoinjectors, namely EpiPen, which is the one currently available in Canada, contains a pre-measured dose of epinephrine. Epinephrine is the drug form of adrenaline, a hormone naturally secreted by the adrenal glands in response to stressful situations. Epinephrine will reverse those adverse effects caused by histamine, namely bronchoconstriction, causing lung symptoms, and vasodilatation, which opens up the blood vessels and drops the blood pressure. The main benefit of antihistamines is in treating hives or skin symptoms and can be administered but as a secondary medication. More on antihistamines. First-generation antihistamines have been in the news lately. And why? The Canadian Society of Allergy and Clinical Immunology has warned against the use of first-generation antihistamines like Benadryl for treatment of rhinitis and urticaria. Urticaria are hives. And this is just from a newspaper article. Benadryl shouldn't be available over the counter due to potential side effects, allergists say. Older first-generation antihistamines like Benadryl have been associated with numerous side effects such as sedation, impairment, cognitive dysfunction, poor sleep, dry mouth, dizziness, as well as being associated with deaths from overdose and accidents. Newer options are more effective and safer. There are longer-acting second-generation antihistamines, almost all available over the counter, such as cetirizine or Reactin, desloratadine or Arius. And we also have two new second-generation antihistamines available by prescription, belastine, also known as Blexten, and ripatadine, known as Rupall. Talk to your allergist for their recommendations, and I will certainly be happy to discuss any further information in your questions regarding first-generation antihistamines. That brings to a close the formal part of my presentation, and I thank you for your attention. For more information, this slide shows you credible resources, and the websites are available at the bottom for further information. These are credible resources in the areas of allergy, and talk to your allergist for further information. Thanks to everyone for their attention as we move on to the question part.
Thank you, Dr. Waserman, for the very informative presentation. There were a lot of questions that came in during the presentation that we'll go through now. So I want to start with the first question about whether we're born with allergies and how exactly they develop. Can you comment on that?
Sure. What people are born with is the tendency to develop an allergy, and this tendency is usually determined by your genetics, namely, are your parents allergic? And what you inherit is the tendency to allergy, not the specific allergy. So if you have parents who have hay fever and asthma, the children of those parents don't necessarily specifically inherit hay fever or asthma. They may have eczema, they may have food allergy. So what's inherited is the tendency, not the specific allergy.
Thank you. Another question, can a food allergy cycle through the lifespan? For example, it's present in childhood, disappears in adolescence, and then reappears in adulthood?
The short answer to that question is probably yes. Though most allergies do develop in childhood, it is certainly possible to develop them as an adult in that part of the life cycle. It's also possible that children will outgrow an allergy, but with continued avoidance of that food may redevelop the allergy at a later date. This is probably less common than people who outgrow and tend to stay outgrown.
Great, thank you. We have a few questions related to food allergens. This one is, if allergens are proteins, how can people be allergic to mangoes, strawberries, and other fruits with almost no protein?
Well, even fruits have enough protein to cause food allergy, and in fact, these are probably on the rise. So, the author of this question is absolutely right. Allergy is developed to proteins, but there's enough proteins in these particular foods to elicit allergic reactions. In fact, many of these food proteins have been identified in what we call food allergen components, and they're actually measurable through blood work that can be obtained by your allergist.
Thank you. Can you also explain what is meant by cross-reactive foods and can they cause anaphylaxis?
Sure. Cross-reactive foods means that they are structurally similar. They share certain proteins which make them allergenic, and this is quite a common phenomenon. And can those cross-reactive foods also cause anaphylaxis? And the short answer to this is yes, they can. We see this in the case of certain tree nuts. For instance, cashew and pistachio are highly cross-reactive with each other, and both can cause anaphylaxis. We can also see it with cow's milk and goat milk. They're certainly similar to each other and also have been associated with anaphylaxis. So this isn't an uncommon phenomenon, also seen within the shellfish family, where you can have cross-reactivity within certain shellfish and they can lead to severe allergic reactions.
Great, thank you. Can you also comment on what is the concern around pea protein for someone with a peanut allergy?
Okay. Peas are legumes, and peanuts are part of the legume family, as are other beans and lentils, etc. So likely the main concern here is that anyone with peanut allergy can have an allergy to other members of the legume family. If they haven't been introduced into the peanut allergic person's diet, they should speak to their allergist about specific testing and food challenges.
Okay, we also have a couple of questions that relate to reactions. The first one is, if someone has a food allergy, isn't there always a risk for an anaphylactic reaction?
There is a risk. There's no question that the sorts of allergens that are most commonly associated with anaphylaxis are foods, medications, and insect stings. And that's not to mean that there are not milder reactions. Not everybody who has an accidental ingestion is going to have a severe allergic reaction like anaphylaxis. There are milder forms of reactivity. People may just get a few hives or some swelling or redness. In any case, however, the question is there a potential? And the answer is yes.
Okay, and the other question relating to reactions, it can be hard to differentiate between mild and severe symptoms. So when is it really the time to use an epinephrine autoinjector?
Good question, one that I probably receive more frequently within my practice than any other. And the answer is that it's not always straightforward. The official definition of anaphylaxis is that two systems are involved, and we spoke about that previously. And certainly, if you see that, if somebody has rhinitis as well as hives, it's certainly reasonable to give epinephrine. However, I also tell my parents or whoever is administering the epinephrine that if there is any severe sort of symptom, that it's certainly reasonable to use an epinephrine autoinjector. If somebody has had an accidental ingestion and they're just short of breath, only a behavioral change, repeated vomiting, severe abdominal pain, in those cases, it's certainly reasonable to inject. If it's just a skin reaction and the child is otherwise well, then symptoms can be observed for any progression. Also, if ever in doubt, inject. Treat as if it is an allergic reaction. And I say all this recognizing that the advice that I give to my parents who may be more experienced may be different than what I tell a classroom teacher who may not be used to watching for this progression or knowing what to look for. There, the threshold for treating may be lower than it is amongst my parents.
Thank you. We received a question about testing, and the question is, how often do you have to retest for known food allergies?
Yeah, there are not really any rules about this, but I'm going to give you my own standard of practice. I tend to see my food allergic children yearly. And if it's for allergens that I know are commonly outgrown, like egg, milk, wheat, soy, I do repeat yearly testing just to check their progression. I also have the benefit of being able to do blood work, and the level of antibody in the blood also gives me a clue as to whether or not they're outgrowing and when I can start feeding them. If somebody has an established allergy that's often lifelong, like peanuts or tree nuts or shellfish, if the skin test or blood work does show a very high level of sensitization, big skin test, high blood work, then yearly testing is probably not necessary. Things don't change that quickly in this business, and those patients I will leave for a number of years sometimes before retesting. There's also other circumstances where somebody may have bumped into their food allergen accidentally and had no reaction. And in that lucky event, I will always retest just to see if, in fact, they've outgrown their allergy.
Great, thank you. The next question has to do about airborne reactions, and the question is, do airborne peanut reactions happen?
The answer is they can. Is it common? Probably not. We described the two circumstances that have been, probably most often associated with airborne reactions, airborne milk powder as well as cooking fish. Airborne peanut, most of the time not an issue. There have been studies where peanut butter was put under the nose of peanut allergic children. The most that would happen was contact allergen if they happened to touch the peanut butter while doing it. However, it's not impossible. If somebody is shelling a large amount of peanut with a peanut allergic individual right next to them, it's certainly possible. So, though not a common scenario, it can happen.
Thank you. This question is about anxiety. And can you explain how you distinguish between an allergic reaction and feelings of anxiety or panic?
Oh boy, not easily is my answer. Especially for people who are not experienced, and even for experienced individuals like myself who do oral food challenges in the clinic, many of the symptoms are similar. Anxious people, just like those who are having an allergic reaction, can experience shortness of breath, chest pain, abdominal pain, itching, and even hives in some cases, though less likely. And sometimes you do have to use some judgment. In the clinic situation, if I see that I'm able to calm down that child whose symptoms disappear within a minute or two, then I can afford to sort of go more slowly and observe what's happening. But if I see that things are not changing even after reassurance, I have to assume that this is an allergic reaction and treat accordingly. I also have the benefit of physical examination, doing a blood pressure, etc. That may not be evident to most parents in this situation. So if you're able to calm down with some, gentle reassurance, then watch and see what happens, but otherwise treat as allergy. And hives and swelling, those are objective. It's really those, symptoms where you really can't quantify what's going on. Behavioral change, abdominal pain, these sorts of things that may be common to most, both anxiety and allergic reactions that are most problematic.
Thank you for that. So we've received a couple of questions on antihistamines. So I'll go through them now. First, can you speak to the role of Benadryl regarding food allergy? There seems to be a movement away from recommending its use and going straight to an autoinjector like EpiPen.
Sure. I think that what's raised here is two issues. There's a movement away from first-generation antihistamines for all conditions, not just for anaphylaxis, for which we never recommended it in our Canadian guidelines. but also for common allergic conditions such as hives and allergic runny nose. So clearly those sorts of symptoms, Benadryl, there's a strong movement away for treatment of those things with first-generation antihistamines. When it comes to anaphylaxis, it's important to know that epinephrine is still the first-line treatment. There are other anaphylaxis action plans where people may talk about mild, moderate, severe symptoms, where in the mild form an antihistamine may be used first. In this case, likely it would now be a second generation, given the movement away from first generation antihistamines.
Thank you. This person asks, I'm wondering if I should be removing the Benadryl from our allergy emergency kit, and if so, what I should replace it with.
Excellent question, and I'm sort of going through the same dilemma here in the hospital. I think that in the hospital there will be a movement away from first generations on account of this position statement. But the position statement talks about chronic use of first generation antihistamines for rhinitis and urticaria, for which they are approved. If you're seeing somebody who's having an acute allergic reaction where we're talking about a dose of Benadryl, to me that may represent a different situation. I would not necessarily get rid of it immediately, but once Benadryl runs out, then replace it with the second generations in your emergency kit. It's also important to know that in emergency rooms or radiology or ORs, Benadryl is still the only antihistamine that exists as an injectable. There's really nothing available otherwise. So, short answer, when it runs out, replace it with a second generation antihistamine. They have the same onset of actions, the first and second generations, even though most patients don't believe it. This is what the studies show.
Okay. The next question is, should we be using Benadryl for topical reactions?
We tend not to, and the reason is not for the same reason that oral first generation should not be used. There's a high incidence of contact dermatitis with these sorts of topicals, so for the most part I tend not to use them nor recommend them, and if there is a problem with an allergic skin reaction, then a topical steroid or oral antihistamine depending on what's going on. For contact dermatitis, it would be a topical steroid.
Okay, thank you. And the next question is, should Benadryl be given for a mild reaction that could escalate into more of an anaphylactic reaction?
If you're going to use an antihistamine, if you're an experienced observer, if there's a mild reaction, only skin related, and you prefer to wait and give an antihistamine initially, at this point, I'm recommending the second generation antihistamines be used in that situation. Though if Benadryl is what you have, that's what you use. I don't believe that antihistamines cover up the progression if it is going to go to a more severe allergic reaction.
Okay, and the last question related to antihistamines. Can you comment on which form of allergy medication, such as liquid, chewable, or quick dissolve, is best?
I have never seen comparative data as to the onset of action of the easy melts versus the liquids, but just based on the experience with all the other second generations that we do have, they all have a relatively similar onset of action within 1 to 2 hours. So in all likelihood, they're all going to behave fairly close for oral and for the easy melt. If there is a difference, then, that becomes important to know, but I haven't seen data that supports that for the most part.
Thank you. So I'm going to shift gears back to allergic conditions. And the question is, can you explain the association between food allergies and eczema?
Oh, sure. This is a fairly well-established connection, especially in children. Those who have severe eczema have inflammation of their skin, and in having an inflamed skin barrier, this appears to allow food and other allergens to penetrate the skin more easily, and sensitize individuals who are predisposed to developing allergy. Not all individuals who have eczema will develop allergy, and not all individuals who develop allergy will start off having eczema. But this is clearly part of what we call the allergic march, where kids who do have eczema and an inflamed skin barrier go on to later develop food allergy in some cases, followed by respiratory allergy such as rhinitis and asthma. In severe eczema, in about a quarter of cases, people also have a genetic mutation which affects the skin barrier epithelium. This component is called filaggrin, and it's been demonstrated through genetic testing, and this has led people to develop allergy. It's also important to know in young babies their skin should be moisturized right from birth because that seems to prevent sensitization as well. Whether you have eczema or don't, a good lubricant given a couple of times a day is being shown to be helpful.
Thank you. I have another question on reactions, and that is, will someone react the first time they are exposed to an allergen?
The classic teaching is that you need some sort of exposure in order to become allergic and to express symptoms once you're re-exposed. The issue is that even if it seems to be a first exposure, often people have been have been exposed earlier than that. Though patients don't often remember. There's so many contaminants in different foodstuffs that what you think is a first exposure may not actually be. But all of those things aside, in most cases, first exposures will not result in allergic reactions, though they have been described. The good news is, at least based on studies, is that most of the time first exposure reactions don't tend to be severe, and luckily mortality with these sorts of reactions appears to be quite rare.
Okay, thank you. I want to ask a question about oral food challenges, and this is specific to teens. The question is, can a teenager undergo an oral food challenge for peanut?
Sure. In fact, anybody can undergo an oral food challenge to peanut at any age, including teenagers. It's never too late to do it, is the message. Look, oral food challenges are done primarily for two reasons. It's to rule in a food allergy definitively, like to peanut, or it's to see if peanut allergy is outgrown. Both of these are important things to find out, and an oral food challenge is still the best way to do it, no matter what age.
Thank you. This next question also relates to age, but it is related to OIT. And the question is, can adults undergo oral immunotherapy?
Adults can, and they've been part of a number of studies that have already been done. The problem is that in adults, their immune response already appears to be quite ingrained, and the data does not appear to be as good for adults as it has been for younger children, where the immune system is still able to be manipulated. So results have not been that effective, and in fact, for the new peanut products that are coming out, in all likelihood, they're going to have an age designation, which is going to be for older children. That's not to mean that some adults may not be inclined to try it, but the data is not as promising. This question also asks about rarer foods. And at this point, our main experience with OIT has been for the primary foods, such as peanut, egg, milk, and some of the tree nuts.
Thank you. Can you become allergic to a food if you reintroduce it after prolonged avoidance?
Short answer, yes. Clearly in people who have started off allergic, who appear to have become tolerant, and we demonstrated that with oral challenge, if they avoid it and avoid it for a prolonged period of time, it's certainly been described that they lose tolerance and they become sensitized again. And this is likely also true for people who've never been allergic but who go through a long period of avoidance, but there's less information on this group of patients. So how common a phenomenon that is, I'm not sure.
Thank you. We have two questions related to epinephrine. The first one is, Does epinephrine become less effective if you use it frequently? For instance, does your body become desensitized to it and not respond to the medication?
Not described. I mean, really, tolerance to epinephrine hasn't been demonstrated with any consistency that I'm aware of. In fact, if you don't respond after one dose of epinephrine, the message is that within 5 minutes you have to give a second dose. And maybe the best information comes from the literature on overdose, where those people, though they experience adverse events, still continue to respond to the effects of epinephrine after repetitive dosage. So what I'd say is that it remains active and that tolerance to it hasn't been, a described phenomenon in most. Now, that's different than those individuals who have never had a good epinephrine response and have succumbed to anaphylaxis. And unfortunately, those cases are out there where people are in the throes of a very severe reaction, and the epinephrine is either given too late or the reaction is just too far gone to work. So fortunately, those cases are few or far between, but there are cases where people have not responded as expected.
Okay, thank you. I think you've touched on the second epinephrine question a little bit because it relates to the second dose. But the question is, what is the likelihood of administering epinephrine to treat a reaction and symptoms continue to persist?
If symptoms continue to persist, then that is the general recommendation that they go ahead and give a second dose. In the vast majority of patients, 2 doses should be enough. We rarely hear about people going on to need 3 doses unless they're in the throes of an extremely severe reaction. But ordinarily, 2 doses should be sufficient for most, which is why we often tell people to carry 2 doses of epinephrine with them.
Great, thank you. I have a question on food labeling.
Mm-hmm.
So if a food label does not say it may contain a certain allergen, can you assume it's safe?
Good question, and in this business, you probably can't assume anything 100% of the time. The primary food allergens do need to be listed. That's the law. The fact that they are missing, however, errors do happen, and, if you want to be 100% certain, err on the side of caution, call the manufacturer, get more information. That's not to mean that these foods should not be tried. If you've, gotten information that you consider satisfactorily, in some cases you need to be prepared to treat, but food labeling has had its issues. And, the other issue is that people get used to eating a certain food with which they've never had a problem, but sometimes the process of manufacture changes, somebody stops reading the label, yet the contents of that label has changed. So keep an eye out.
Thank you. I think we have time for one last question, and it's about cleaning. Can wipes sufficiently remove potential allergens from surfaces in public places and other spaces?
Yeah, this has been looked at in a couple of studies, and the results show that good old-fashioned elbow grease with soap and water appears to be the most effective in removing allergens. And this has been looked at most closely for peanuts, so that's what I'll comment on. Wipes still leave behind a residue, so where you have a choice, soap and water over wipes.
Thanks. We have had one more question come in that I think would be important to address. And the question is it okay to keep expired EpiPens around for a period of time as backup to current EpiPens?
Short answer, probably. And in fact, in the times of shortage, this was the recommendation from Health Canada. Don't throw away your expired EpiPens. Look, based on what we know, that medication is likely still effective for the next 6 months to a year. It's not a preferred course of action, but to keep it around as backup when you do have a viable in-date autoinjector, I don't have a problem with that for a limited period of time.
Thanks very much, Dr. Waserman, for your very helpful answers to the questions on such a variety of topics. As a reminder to the audience, you will get a short survey through GoToWebinar immediately after this webinar that will pop up on your screen. You'll also receive the survey in an email in the next hour. So we ask that you please take a few moments to complete it. Your feedback is crucial in helping us improve our future webinars and to also better understand what additional questions you may have. As it's the season of giving, please consider donating to Food Allergy Canada. We are a nationally registered charity, and we rely on your donations to provide services for free, like these ongoing educational webinars, to support the community and to help us advocate on behalf of all Canadians impacted by food allergy. We would be grateful for your support, so please visit foodallergycanada.ca/donate to learn more about the impact your donations will make. We also thank our sponsors for their contributions to our ongoing webinar series: Pfizer Canada, the Sean Delaney Memorial Golf Classic, the Walter and Maria Schroeder Foundation, and the Peanut Bureau of Canada. One final detail: we'll be taking a closer look at some of the topics that we covered during today's presentation during our 2020 conference in Toronto on Saturday, May 30th. The full-day conference will be centered around how to create a better future with food allergy, including sharing the latest in research from around the world, beyond treatments and therapies. You'll also have an opportunity to network with others impacted by food allergy and check out various exhibitors supporting the food allergy community. There will also be 2 half-day sessions for youth, with one session for ages 7 to 11 and another for ages 12 to 17. So save the date, and please make sure you're signed up for our emails so that you receive information about this event. We hope to see you next May. Thank you everyone for your participation in this webinar. Once again, you can view a recording of it at foodallergycanada.ca shortly. Please also share it with others who may benefit from the information. This now concludes the webinar.